before that, I was also working in the UN. Currently, I'm advising the foundation, the Bill and Melinda Gates Foundation, on regional programs. So that made me moderate that session. This is a session which would welcome comments on the universal healthcare system, focusing on South Asia. As we know that health has been a fundamental component of civilization. It has featured quite prominently both in the MDGs and SDGs, and lately also featured in the climate change debate, in particular in the context of climate-induced health issues, both long and short term. Please, we were looking for you. So we would listen more, and as I am not expert in the health, except ending up in the hospital on and off, so we'll hear from experts. We have around 7 questions. I'm not going to divide. I'm going to read out the questions, the focus, and invite the panelists to pick from there. I have 4 panelists, so I'm better off in terms of allocating time. Although it's written 5 minutes to start with, and then dialogue, and then 2 minutes to end, but we will see how it goes. So I have on my right Dr. Rabindra Rana Elia. Could I correctly pronounce it, sir?
It's okay.
Okay, good. He is from Sri Lanka, Executive Director and Fellow Institute of Health Policy. I have heard that he will share a lot of ideas and programs with us. And then we have Dr. Buddhu Setwan, Buddhi Setwan, Chief Health, UNICEF Nepal. And then Dr. Pulasti Amarasinghe. See how confusing the South Asians are? A research fellow at the Institute of Policy Studies of Sri Lanka. And then you have Kamal Chulagain. This time I'm correct? Yeah, good. Research Associate, Nepal Development Research Institute, Nepal. So we have 4 speakers. I am going to sort of lay the major area that we would like to hear from you, and also subsequently by the participants. And then you can choose, and I'm sure the organizers have also shared with you, but for the better understanding of all our panelists, I will quickly go through it. We would like to identify the barriers of universal health coverage. I don't think we should be going into conceptualizing universal health coverage. It's pretty defined by the WHO 2023 report. And there seems to be a consensus among the state parties on this, because the state parties normally do not agree on anything, because they then take a burden. And then the model as to how you finance the coverage, going into the participation of both private sector and the civil society. And naturally, when you talk about health coverage, it is the minorities, it is the people who are living on the margin, not only in terms of income, but also in terms of geography, how to reach them. And then whole issue of technology. And they certainly end up with the regional cooperation. So that's how we intend to it. But let's start with Dr. Rabindra. You have 5 minutes, and then I'm sure we can have more times to listen to you.
Sure. Thank you very much. So I want to just give a very quick definition of how I understand UHC. They're basically 2 things. We need high equitable levels of access to healthcare, and that should be demonstrated in actual use patterns, and financial risk protection. Those are the 2 key elements. And just in terms of my experience over, I guess, 30 years working in many countries, and from what I studied around the world, they're basically, traditionally, we talk about 2 traditional or 2 conventional routes to UHC. But I would now add, based on experience in the region, a 3rd approach. But what are these 3 approaches? And I just want to put them out there. The first is a national health insurance model. This is the German social insurance from Chancellor Bismarck in the 19th century. But but combined with taxation to extend insurance to the people who cannot pay premiums, right? So this is not traditional social health insurance. This is national health insurance. Insurance plus taxes. And you see the best examples of that are Japan and Taiwan in our region. Then there's a predominantly tax financed public delivery system. Often in our region, we think of the UK NHS, but in fact, New Zealand has an older model, 15, 20 years older than the UK, and that's another approach. Now, what's this third approach? This is not a traditional model, at least in the literature, but it does work and it exists in our region, is what I would call a hybrid public and privately financed delivery system. You have a parallel public system and a parallel private system. And examples of that are Ireland and Hong Kong. You'll notice both were former British colonies. Something common with us, well, at least many of us, sorry. No, it's not Indonesia.
We have to leave the bind.
Yes.
Of this room
Interesting, Ireland and Hong Kong don't have the UK NHS, but they actually have better health outcomes. So it's a system that works. Now, what's the challenge? The challenge in UHC is not a technical problem. I'm a technical person. It's not a technical problem. It's not per capita income. The basic challenge to UHC is that in general, in all societies, the poorer citizens, the majority, they highly value UHC. They value access, they value risk protection. But the problem is political economy, because to solve that problem and meet their needs, you have to transfer, redistribute resources from rich to poor. And that's a political problem. And UHC typically only happens when there are political windows of opportunity and the political economy is supportive. Now, what have we done in our region? There are some examples of reasonably good UHC attainment. Sri Lanka's one, Maldives, Brunei, Malaysia, Singapore, and Thailand. How are they doing it? Interestingly, none of them have a national health insurance model. You have Brunei and Maldives, predominantly an NHS model, but they're tiny places, so probably not worth discussing. And they're all upper middle income. There are predominantly, there's a Thailand, which is a tax-financed quasi-insurance system, but it's predominantly tax-financed. A lot of people think it's insurance. No, it's funded mostly by general revenue taxation. Thirdly, is this third model, the hybrid public-private model. You see that in Sri Lanka, Malaysia, and Singapore. Now, what are the critical factors for getting to UHC? I think political, as I said, you need a political system that is responsive to public opinion, and you need political windows of opportunity. If I take the case of Thailand, the political window of opportunity was the election of Thaksin Shinawatra as prime minister. He used UHC as a way to win an election and win political support. He was so successful that the only way they could get rid of him was to have a coup d'etat, right? The military could not get rid of him. They kept on banning his parties, right? That was very effective, maybe not for him personally. The other critical factor is tax collection. Obviously, you need it for a tax-funded system like an NHS. In the UK, you need taxes. The UK had to increase taxes by 1% of GDP to establish the NHS in 1948. It would cost more today. But even if you do social health insurance, it doesn't get away from the problem of taxes, because if you want to cover everyone, like in Japan or Taiwan or Germany, you need to use taxes to pay for the poorer people. Insurance is not a panacea for not taxing people, right? And that's a lesson many of our elites do not understand. You also need state capacity to run health services. I mean, Sri Lanka has that, Thailand has that, Malaysia has that. And even if you want to do insurance, you need very specific technical capacity. It usually comes from having a history of insurance, which many of us in South Asia do not have. And then one barrier is, I think, elite beliefs, particularly in our region, that they think the solution to getting UHC is private financing. And I see this in the document also. And maybe Gates also gets that sometimes. Yep. And panacea, that insurance is somehow a solution, a magic solution to not doing the basic work of taxing rich people and building capacity to run public delivery systems. I'll just finish quickly, 5 minutes. thoughts on future, just some random thoughts on future enablers. I think democratic governance. It's very clear to me that, and I gone to Bangladesh about 30 times over the past 25, 30 years. Bangladesh advanced when there was democracy and there was electoral competition. That's how Bangladesh made huge advances in health. And we know democratic governance suffered in recent years in Bangladesh, and it currently does not have a democratic government. Same for Pakistan. If you look at some of the most progressive and from a UHC perspective ideas in Pakistan, they came when politics became contested at election, particularly Imran Khan's had some very interesting ideas. So we need, and Thailand, all these countries need to move back to democracy. For the countries with democracy like Sri Lanka, Malaysia, India, Indonesia, we have to strengthen the democracy. If you look at some of Sri Lanka's problems in recent years, we've been a democracy, but our democracy has become dysfunctional, less responsive to the ordinary people. And finally, we all got, most Sri Lankans got fed up and they voted all the established people out very recently. Now, one other thing about regional cooperation, I think we need to learn from regional successes, and we don't do enough. Somebody was telling me just yesterday, people want to go to Thailand all the time. The Thai system may not be very helpful to countries like Bangladesh because Thailand has 4% of GDP from government tax revenues spent on healthcare. If you're Bangladesh and Pakistan, you don't want to raise taxes. That's not a solution, right? So you need to look at what's going on in Sri Lanka and Malaysia, even Australia. Why these are important, I think, is that they found a solution to ensuring UHC with limited fiscal resources, which depends on building public services which are genuinely accessible by the poor, and then essentially depending on the better off opting out and paying privately. But managing that is not easy. You have to learn from the historical experience. And the other part of that is that you have to strengthen healthcare management. And that's not a technology issue. It's not simply having more people. It's about how do you strengthen the internal management mechanisms, particularly in public sector delivery systems, to get this to work. And public sector delivery matters because unless you're in the situation Japan and Taiwan, where all provision is basically private, what we all have, and this applies to Indonesia, applies to India, is that we still have predominantly, we have large public sector delivery systems. We have to get those to work well in order to achieve UHC, whatever else the private sector does. Thank you.
Thank you. Thank you very much, Dr. Rabindra. In my note, there were 7 models, but here I've reduced it to 3 models, helping us in terms of thinking. Number 1. Number 2, I take it that democracy or the governance in broader sense of how you run your state helps not only health sector, but also the other sectors. And I think by that, you are also sort of alluding us to think that health sector is based on a development model. It doesn't have a model out by itself. It has to be incorporated into development models. We take that, and there'll be more opportunities to have discussions around that. And it is not the technology, it is not the Bill Gates and Melinda Foundation, but it is the governments willing to invest in terms of resources for the poor. So there is the political model that we are looking at. Whether the new liberal model is a conducive model for creating health facilities for the poorer sections or not, I don't know. I'd be interested to see how England did it post industrialization. I think that's where the beginning of their health facilities. I have availed of that. Very good. So good. So now we have our colleague from UNICEF. Let's see how UNICEF is looking at some of the health issues. Dr. Buddhi, thank you. You have all the wisdom.
Thank you, Chair. So I've been with UNICEF Nepal 4.5 years, and before that I was in Myanmar, and before that I was in Indonesia. But basically, still like half of my career have been spent in Indonesia, and actually I learned about health financing for UHC from Ravi. So This is again a bit of reunion, yeah, a bit of reunion for me as well, and 15 years ago, just to be exact. So I just want to highlight maybe because I can't really add more about what the excellent points already shared by Dr. Ravi. But one thing that's very clear, I think it's very true about the political solutions. So looking at the issue that we have in the region, I think with the overall spending of GDP for uh, health is very low. That's very key area that we need to work on, in terms of our advocacy. And for UNICEF, I think it's very clear because then when you talk about prioritization of resources, again, when you talk about universal health coverage, what we saw from our earlier example in Indonesia when we rolled out that uh, the core issues like maternal, newborn, child health, they were left out somehow, like, and this is something that we saw also apparently in Nepal. So just to think about also in terms of the way we spend already the low GDP spending, but also in terms of the allocative efficiency, in terms of interventions to advance universal health coverage. So on the financing solution, I think the one thing that I would offer as well, looking at the examples, is really the strategic purchasing reform, which is something that we may need to see, like what now Nepal is trying to do, because just to again rely on the public sector as well as um, the limitation in terms of the uh, government capacity to be able to implement the health insurance, for example, is a challenge to really complete the picture. And just to touch on also the point Ravi mentioned about the private sector engagement. So I think we can also learn from Indonesia's experience in engaging private hospitals through JKN, because in reality, 60% of the secondary care approach, they are actually purchased by JKN through the private sector provider. So it's doable. If you have also a strategic purchasing reform, then you can do it as well, and you can expand your service as well. On the issue of equity, so the thing that also we need to mention that the basis of all of this work should also be harnessed around the primary health care approach, because I think the focus of UHC has been always secondary tertiary care elements, and I think we need to try to get this back. And again, coming from experience also in Nepal, I think what is Nepal doing is commendable, because then they work on more, let's say, on the universal maternity scheme with the AMA program to actually get also the maternal newborn care package, first to be fully covered, and through the constitution obligation to fulfill the basic health service, while also working then the secondary care package through the national health insurance system. And I think without um, all of us should also agree that when you talk about primary healthcare system, we should also think about the community engagement component. And this is something that we should also work on in terms of both the supply side financing, but also even to support the financing to really alleviate the um, demand barriers, which needs to be addressed by community engagement. For example, one thing that it is not addressed in my experience, let's say, in terms of observing the universal health coverage system, is really about the remuneration and support for the female community health volunteers. They are the forefront of our public health interventions in immunization, etc. But they are not included in the whole financing schemes of, you know, either the government, in terms of sustainable financing, but also in terms of including them is part of the preventive package in universal health coverage. And lastly, I think the one thing that, of course, very close to us, UNICEF, is really the um, equitable access when it comes to having also the poorest to be the center first. So it's always the challenge, right? And this is what we've been discussing also in terms of the moral hazard, because when you talk about universal health coverage through, let's say, national health insurance systems, the one benefiting first would always be first, the one closer to the access, and those are actually the better off population. And that what we saw also in the initial rollout of Indonesia JKN, because then actually the majority of claims, they are coming from the richer segments. And that's why I think the one really commendable effort that Indonesia did, like then 40% of the poor actually they are fully subsidized by the government. So this is something that can be done, incrementally also, through a more affirmative approach. And on regional cooperation, I think this is something that is a bit tough in terms of our context in South Asia and South Asia because of the diversity of the context. But the two areas where I think we can leverage is really about the democratic governance, as mentioned by Rafi, but also when you talk about comparison in a region, I think it's also about the political prestige of having actually a shining model, in the region. And this is something that somehow, in maybe in our South Asian culture is, maybe more prominent. We can work on more exchange learning between countries, but also at the same time, maybe we would like to also have a methodical approach in terms of building capacity of policymakers, also of the technocrats, in ministries of health, or also the national health insurance regulators to get the skills and knowledge and technical capabilities to also reform the system in a more systematic manner. Thank you.
Thank you very much for highlighting again the policy, politics, and the governance issue in terms of coverage. But I think you pointed out a very important issue in terms of fault line in our health coverage system. We all end up seeing the specialist, even if you have a fever or a normal cough and cold. So that's I don't know. In Bangladesh, it's going to a primary healthcare facility. It looks like that I'm not actually seeking um, the best of the best treatment. So that's a huge barrier, because most of the specialists end up looking at patients which he or she should have never attended to. There are other doctors, which you pointed out, the primary healthcare system. The primary healthcare system, unlike the UK and other places, has never been developed. There's nothing next to your house where if you have in the morning cough and cold, you go and see and then off to the office. That culture is not there. So that's a very right point. Whether we can bring that back, that's an issue. That will also then create less burden on the tertiary and secondary health system. Thank you very much for that. Now we go to Dr. Amarasinghe for. I think, I don't know. I always thought I'm rightist. Looks like that I'm leftist. Maybe after listening to the SAS, with the class struggle featured prominently. So, please, you have the floor, sir.
Yeah, so thank you for inviting me here. So as you know, Dr. Ravindra is here, and he's an expert on the Sri Lankan context. So whatever I have to say is probably going to be a subset of whatever he can share. But let me try to maybe at least add a few things onto what he mentioned as well. So we, as you see, in Sri Lanka and in other contexts, financing health, it seems like it is one of the major issues, right? So in the Sri Lankan context, of course, we have had a bit of a opportunity with the IMF coming in and the taxation, the tax targets being set in the areas of, let's say, the health taxes. So, tobacco and alcohol. And, we have been able to capitalize on those to increase taxation. But once again, those taxes, while have very good health effects. Basically, the target of those taxes, is basically improving health outcomes in the long run. They can also, from a government's perspective, especially governments that are short-lived or they don't necessarily last for more than a few years, right? So from their perspective, these are revenue mechanisms, right? So for example, so this use of health taxes, or basically let's say alcohol, these can be a little bit tricky because some governments may just give out alcohol licenses to increase revenue, increasing the availability of a bad good to then tax it and then make revenue. So you have to understand the priorities of the stakeholders involved, especially as researchers here. Understanding these priorities of understanding the political landscape. Who are the political actors? What are their priorities? It could be someone in the parliament, who has a much bigger stage than the rest of us in convincing the public about certain policies. So we need to be aware of who's who in terms of collecting generating revenue through these mechanisms. And it's a bit of a tricky model because financing is one of the more important. I mean, it's one because in Sri Lanka, so the actual amount of public expenditure, I think it's around 2%, right? Not necessarily 10%. So we really do health for public spending for 2% of GDP. Yes, I think the overall spending, public and private, is around 4%. So as you can see, there's a huge increase of huge demand, huge need for funding in these sectors. And recently we have had a large increase in NCDs, and add to that, climate change that's affecting the other, vector and waterborne diseases as well. So the health sector itself needs a lot of fortifying against all these additional shocks that are happening in the economy, whether it's COVID, whether it's climate change. We have frequent floods, uncertainty. So there's a lot of funding that's needed. But of course, in a cash-strapped country like Sri Lanka, where provincial governments, when they receive money, 90% of it is probably spent on wages. So the rest of it has to be spent on some sort of capital expenditures, and that goes to the politicians, where something like building something like a road would be probably better for the election outcomes, right? So you had, once again, thinking about the relevant actors when it comes to financing, and also thinking about other ways of improving healthcare, or preventing the cost, health costs to the government and the society. So other ways could be simply integrating technology, right? So we haven't really worked with on integrating technology when it comes to health, especially in our region of the world. So one recent example I can bring up is there's University of Wayamba in Sri Lanka, and they have worked with IFRI to come up with this app where, so this is more towards prevention when it comes to NCDs and health costs, where they can take a photo of their meal and it'll give an idea of, it'll track and give an idea of the nutrients and the composition. So these are things that in the long run will affect these NCDs and at least try to prevent them. So bringing in the private sector, bringing in these organizations in these areas of technology, bringing information, changing these behaviors through these small nudges. These are things that can be done without waiting for long-term structural changes in the economy. And it should be part of what we want to do in terms of bringing down the health costs to the society and the government, right? Especially in these contexts. So we don't necessarily have to wait for long-term changes, which are highly reliant on external shocks and also the governing system, right? I'll stop there.
Thank you very much. While we were talking about the Sri Lankan contribution in the health sector in terms of GDP, I saw that Southeast Asia's average is about 5%, and Bangladesh is at 3%. And I think, and sitting here, 3%
total.
Yeah. So I was sitting here and I said, really, where the money goes? That's the question. Does it go to the poorer sections or creating buildings? That's the fundamental question. Even if it is, say, 3%, it is almost close to the education sector in Bangladesh. So where that money is going? Why then the government health services so poor? Some kind of a system loss is happening. So that's where I think we possibly need to focus. And it was interesting that at the end everything ends up in power relation, no? The election. So I think if you want to improve the health sector of South and Southeast Asia, you have to make this an election agenda, as you have suggested in terms of Thailand, although it didn't survive. Okay, good. So these are also thoughts which we can then ponder on at a later stage. We have a lot of time. Can I come back to you, sir, Mr. Kamal? I don't know where you will focus. I was sort of thinking that would it be convenient for you to bring in the whole issue of technology into the health, if that's your area of expertise. If not, then we can come back to that from someone else. Thank you.
Thank you, Professor. I'd like to highlight on the barriers and then on the technological part. Basically, universal health coverage is a cornerstone for sustainable development, actually ensuring everyone's receive essential health services without financial hardship. And despite significant commitments and progress, several barriers continue to impede the realization of this goal in this region. And as the previous panelist also highlighted, the insufficient healthcare financing as a critical challenge. Many countries in South and Southeast Asia allocates far less than the WHO's recommended 5% of GDP to health. For instance, in Nepal only spends 1.17% of GDP on health, while Bangladesh allocates 0.74%, which is far below the global average of 6%. And basically, this chronic underinvestment leads to inadequate infrastructure, limited access to essential medicines, and an overburdened healthcare workforce. Out-of-pocket expenditure magnify the financial hardship, accounting for 54.2% of current health expenditure in Nepal and over 60% in countries like India and Myanmar. And it's even high for Bangladesh, that is 73%. And alarmingly, this out-of-pocket expenditure cost push millions into poverty annually, including an estimated 55 million people in India alone. Also, talking about the inequities in the health care access remains a significant obstacle, particularly for rural and marginalized populations. In South Asia, nearly 70% of our rural residents lack access to essential health services. Talking about the Nepal, the national average for child stunting is 25%, and when we see at the Karnali province data, it's 36%, reflecting unequal access to nutrition and health services. And also talking about the maternal mortality ratio, the national data shows 151, but it increases to 207 deaths per 100,000 live births in Lumini province, emphasizing the urgent need for targeted interventions in underserved regions. Similar patterns we can observe across the South and Southeast Asia, where cultural, linguistic, and also the logistic barriers further isolate vulnerable communities from adequate care. The another challenge, as highlighted by previous panelists, is the shifting burden from communicable to the non-communicable diseases. In South Asia, NCD now accounts for approximately 65% of total deaths, with cardiovascular diseases, diabetes, cancer, chronic respiratory diseases leading the toll. Nepal mirrors the trend where NCDs are responsible for 75% of all this. Hypertension affects 26% of Nepalese adults, while diabetes prevalence has reached 10%. Mental health issues are also in increasing order. We have the societal mortality rate in Nepal standing at 23.9 per 100,000 populations, among the highest in the region. And this epidemiological transition places immense pressure on health systems that has historically managed the infectious disease, and we are not able to manage the non-communicable diseases through our interventions. Also, the fragmented health systems further undermine universal health coverage efforts. Poor coordination between public, private, and informal healthcare sectors create inefficiencies and gaps in service delivery, particularly seeking the examples of Nepal. The fragmented implementation of Health Insurance Act has resulted in low enrollment rates, with only 28% of the population enrolled, leaving many with financial protections. And also we have the high dropout rate for these health insurance systems in Nepal, and we need to work on that. Another problem we have is the workforce shortage and maldistribution, which also add challenges to the universal health coverage. Basically, the Seru region faces a critical shortfall of healthcare workforce, with the WHO estimating a deficit of 4.3 million workers. Particularly talking about Nepal, there are only 0.83 doctors, nurses, and midwives per 1,000 populations, far below the recommended 4.45 per 1,000. And basically in the rural areas, they remain underserved due to the poor retention and motivation among the healthcare workers, further widening the gap in healthcare delivery. And this is the trend in other South Asian countries also. And another barriers is the governance and policy challenges, like we have a weak governance structure, corruption, and poor budget executions, which divert resources from critical health interventions. Basically, in Nepal, when we talk about the budget, allocated budget, only 72% of the allocated health budget is spent, highlighting inefficiencies in fund utilization. Transparency International has identified corruption as significant issue in South Asia health sectors, further undermining equitable access to healthcare services. And another threats we see as the emerging health threats and the impact of climate change further strain already fragile healthcare systems, like the 2021 flood in Bangladesh, for instance, disrupted healthcare access for 4.5 million people, highlighting the vulnerability of health systems to climate-related disasters. And also the pandemics like COVID-19 similarly diverted resources and attention from long-term USC priorities, leaving gaps in health coverage and preparedness. Basically, to address these barriers, some actionable points can be proposed, like the government must prioritize for the health, and health financing should be increased to at least to the WHO recommendation. It can be done by increasing to the 5% immediately in the next year, but a gradual increment should be there. And also the innovative mechanisms such as health hazard taxes on tobacco, alcohol, and sugary beverages can provide additional resources. And while seeking the examples of Nepal, we are at the list of taking the taxes on tobacco, and this is the fact. So we need to we can secure the additional resources from the taxation on tobacco, alcohol, and sugary beverage. Second is equity in access should be promoted through targeted interventions for marginalized population. And basically talking about the programs in Nepal, we have Safe Motherhood program that have successfully improved skill delivery rates and can serve as a model for replication in other countries too. Expanding mobile clinics and telemedicine initiatives also can help bridge gaps in underserved areas. Basically, we need to focus on the system integration and strengthening collaboration between the public and private sectors, and leveraging interoperable health information systems also can reduce the inefficiencies. And investment in human resources are also equally important, with training programs, rural development incentives, and tax shifting initiatives proving effective in improving workforce distribution and capacity. We need to focus on the good governance and transparent accountability mechanism, and community engagement in health system design and monitoring also can ensure resources are utilized efficiently and equitably. Finally, we need to build resilient health systems. That is much essential. And integrating disaster preparedness into health planning and expanding programs like the Nepal's one door crisis management program can help a health system respond effectively to crisis while maintaining progress towards USC. I'd like to conclude USC is in South and Southeast Asia is ambitious, but it is still attainable. So we need to work together and have innovative thinking and sustained commitment from government, civil society, and private sector is the must. And we need to have all hands together for this universal health coverage. Thank you.
Thank you very much for sharing the situation in Nepal with us. I'm sure there will be questions. So with this, we come to the end of the first round. the floor is open for questions, statements, as you wish. And then, yes. Yeah, absolutely.
Yes.
Absolutely.
Yeah. So thank you. So maybe I just want to share a bit about the digital health component. So um, I think what we need and what we need to, really have a better approach in exchange learning is exactly this area. Digital health transformation, I think, is a key to actually have really a good UHC, but with accountability. Because I think if you have the data coming in, you have the facility registry, you have the health workers registry, you know, and all of them actually within the a great, or a functional, sorry, health information exchange platform, uh, those can be done. And this is something that I personally learned, you know, with my own experience when I returned to Indonesia after the lockdown, everything. I returned back to actually visit my family, and how the leap, you know, happened. You know, I could not buy my ferry ticket from Java Island. There is a town, to cross the Bali Island. I could not buy the ticket if I don't have my COVID-19 vaccination certificate online. You need to scan, you need to buy the ferry ticket online, you need to include your vaccination card, status there. If not, you cannot buy. Even if you still have your own family members with you coming in the car, in the ferry, they're not vaccinated. I have two young sons at the time, right? You can see how that interoperability happened. How uh, the company is called ISDP, the ferry provider. How can they link their purchasing data with my ID card and my vaccination card? You know, I felt like, even me as an Indonesian, I felt amazed. How you can make that happen. And this is something that then it's doable. You know how actually you have 8,000 facilities to be connected in a system. How you have 10,000 primary healthcare centers to be connected in the system. You know, and what is the drive, if I may ask? It's money. Those facilities would like to get their capitation paid, right? And they need to beef up, you know, both their quality of care standards, including their infrastructure improvement, including to link. Because if you're not linked with the Satu Sehat, then what happened? Then they're not getting paid by the insurance, right? So you have a clear motivation actually to try to make first the interoperability happen, but also in a system where the strategic purchasing can also be used to drive, you know, both the quality of care but also accountability in terms of providing the right service to the right population. And this is why, even if you think about it, how come, the insurance system can actually even somehow enforce 60% of the secondary care providers coming from the private sector. So the government basically, right? They bought the service from private provider. Look, you need to be enrolled in my system, and you're getting money. Of course, in the beginning, I remember clearly when you talk about benefit package, etc. There were fights because they feel, oh, the payment is so low coming from the insurance, But at the end, they will meet in the middle. So you have also systematic ways to address those by iteration of data coming to the system. So 300 hospital using the EMR, because also one thing that I learned from Nepal. Nepal is smaller country, right? 30 million people. Then you can actually have a push. If now they want to be enrolled in national health insurance system, then you need to beef up your electronic medical record system. So I think there are ways forward. And this is something that we saw clearly, tracking at individual level is also even doable. Now we learn like how India is now going to do the RCH 2.0. Can you imagine how many billion people? They want to track individually with RCH 2.0, from the whole continuum of care, from from the kids born, to the end. So I think it's something like the technological leap, and also more important, I think the political commitment that we need to instill also, in the region. And you can see the examples that with political commitment, I think is doable. Thank you.
Thank you very much. I was sort of listening to Dr. Buddhi and thinking why it happened and what triggered it. It's the threat to the existence of human being. That only made things that had happened in the COVID period. It wouldn't have otherwise happened. It would have taken 10 years to do how we have digitalized the health services. So we possibly need another threat. Huh? So that we come out with the right choices. Anyway, I'm not threatening anyone here. Let's take questions, statements. The floor is open for that. Thank you. Yeah, please.
Thank you.
I'm not threatening anyone.
Okay. It's mutual cooperation.
It's mutual cooperation.
Yeah. So, okay, I have just two points to where I would like the respondents, I mean the panelists or any other colleague can talk about. One is the type of or structure of the government and its linkages to the health coverage, universal health coverages. Just to give an example, like Pakistan, India, Malaysia, and now I think also Nepal has the federal structure, where health is the provincial subject. And particularly in the case of Pakistan, we have 4 provinces. So if federal government and the provincial government, they belong to different political parties, so it becomes really difficult. For example, in the last government, when we had one party governing in federal, and in 2 provinces, and in other 2 provinces there was another political party. So the initiative that you talked about, the Imran Khan government, so it was implemented in 2 provinces but not in the other provinces because of the political tensions. So how I think maybe you can, the colleague from India can talk about that, how it is in India, but because they also have the same kind of structure. In India, it's 2/3 of the public expenditure on health is done by the states, and in Pakistan it's more than 80% by the provincial governments. But there is a tension between that. And second thing that I would like to listen from the panelist is this. Well, I'm very fond of the market economy, but the role of private sector. What we see when overall the regulation is not there, the sector is not well regulated, then we have problems. For example, we all know that the nexus between private health providers and the pharmaceutical companies, so they can undermine the whole system. So I would like to hear from the panelists.
Thank you, Chair. 2 quick points. I mean, just not to question, I think more of an observation. Maybe I can hear, particularly Dr. Ravindra. Very good. I think being in Thailand for years, I can say something about the Thai system. Actually, I think I strongly agree with the point. It is a political will, that the political will of the government, that I will provide universal healthcare to my people and make it almost free or very cheap. I think this first. Secondly, I think it is a system more comprehensive because it's linked with social security. If you are a Thai citizen, you as individual or your minority members of your family known to you, you bring them in the social security system so that you can use that card. If you are poor, you don't have to pay, but you are part of the social security system. Even after retirement, you make a claim for pension, universal pension system. So look at the public policy on that. But I think there is a flip side of the coin I prefer to share with you. One is actually, I think, a bit interesting for us, I think, is the issue of health tourism, which I think Singapore, Malaysia is trying to join. Thailand are pioneers. That has created, I think, benefits, but also problems. Let me go for problems, because the problem is the recent debate in Thailand. If you look at Thai healthcare system, education system, only one small medical school is private. The whole medical education is public. Government did not open up the market to the private sector. I think Bangladesh has to learn from that. Maintain quality at the same time, putting public money for healthcare to create the skill. But at the same time, there are people who are raising question, because if you are a high-end medical professional like a doctor, you will prefer to spend more time given the time limitation in the private clinic. So some people are raising question. Thai taxpayers are producing those doctors, but they are serving foreign patients. So this is an issue has to be taken care of. I mean, that is a policy dilemma Thai government is having. Sorry, I'm taking more time. One issue is the social security has an issue of, I'd say, sorry to use the word bankruptcy, because if there is not a no regular resource flow, you will be affected by that. Already people are raising concern about Thailand's long-term financing of social security, because it's mostly publicly funded. Government is now thinking to, introduce bonds to get some go to the capital market, but there are risks, particularly given the aging population and the slowdown of the economic growth of Thailand. So all things have to be, I think, kept in our mind for other countries if you try to learn from them. Thank you very much.
Yes, please, sir.
Just a very quick question. Uh, the many of the health outbreak is triggered by disaster and climate related, particularly water and vector-borne disasters, floods, tropical cyclones, and cholera, heat waves. The point I wanted to flag is there was a Sendai framework for disaster risk reduction. And there is a Bangkok principle which Thailand promoted this. This year, there was a midterm review of Sendai framework, and the most disappointing progress has been reported on the health aspect of disaster risk reduction. And this has been primarily because the health is not included properly in national disaster risk reduction strategy. The point which I wanted to flag is the health medical sector of government. It's across the multiple sectors. So it is important that you should take this opportunity to create a multi-sectoral approach for addressing health issues. Thank you.
I'm sure the panelists are taking note of it and they would like to answer some of them. Yes, please.
Yeah, I want to uh, learn a bit more about the work Dr. Pulasti is doing, yeah, IPS is doing on your tobacco research. Yeah, I think it would be a very good example for us to learn, especially in India, right? Nepal also, we have been doing this work on the tobacco taxation since the last 5 years, and we have been recently awarded the Health Minister Prize from the Ministry of Health. So I think these are some of the success examples. I think it's the same case in the IPS. This could be a good cross learning for other reason, but I'm not sure how does this our work on the tobacco links with the universal healthcare system in general. So I want to learn a bit more on this from Dr. Pulasti, and maybe Kamalji can add, and similar other examples in other regions if there. And this is open to all the panelists. Yeah.
I feel pity for the smokers here. Yes, please.
Thank you so much for all the panelists for your wonderful input. I just had a question. I had two-pronged question. First to Dr. Ravi. Firstly, I would like to learn more about how Sri Lanka has addressed the urban-rural health division. So in Bangladesh and other South Asian countries, we see due to the privatization of hospitals being more central to the urban areas, there's definitely specialized services that are less available in rural areas. Moreover, within the urban care mechanisms, there are dense population, but with limited healthcare as well as community healthcare being absent in some regards. I just wanted to understand more on that. And secondly, if we do consider that the health agenda itself is going more on a national election or a political basis, is there any regional health agenda that is in development or is a possibility? For example, in the earlier session in the morning, we saw climate change being more of a regional approach as for cooperative. But can we see it in for can we see a similar model in health? And my second question is to Dr. Buddhi, and thank you so much for highlighting the primary healthcare focus, as well as the MNCNH, which does require a more specialized approach, which also includes immunization. So I just wanted to understand the research and innovation that is required for sectors like immunization, MNCNH. How do you have any models of UHC that encompasses that, especially within the global south? So I would love to hear and know more about it. Thank you so much.
More reflections? Yes,
Something.
please.
So I've been working in American healthcare system since last 25 years. So I have built multiple EMR and EHR systems, like Dr. Buddhi said, for big American billion-dollar companies. And so I'm still involved with them. That's one part. So another, Dr. Ravi, like you said about USC and the Germany style Bismarck model. So America, so we are proposing to American government to adopt Bismarck model of Germany. So that's one part. So while approaching the universal healthcare with taxation on tobacco and alcohol, actually what critical scientists say is that there is no scientific proof that tobacco causes hypertension. There is no scientific proof that tobacco causes heart attack. It does not cause cancer. But those people who are genetically defected, so and if they use it, then there is more chance of getting diseased and die. So that's one part. And Dr. Kamal, so Nepal government is not addressing the problem of 70% of Nepalese who have mental health problems. 70%, it's not a joke. And these similar kind of people have hypertension. That's the major problem. Even my heart doctor was telling me, oh, it's not only your problem. Everyone has similar liver in Nepal. Yeah. So, okay, thank you. Sorry, anything?
Obamacare. Huh?
Dr. Buddhi, you talked about digital health in Nepal and trying to promote that. Ministry, the Nepal Health Ministry is working on that. But I attended some of the programs that they have started with respect to digital health enterprise architecture. You know, what as a health system needs to be incorporated. And for some reason, the entire traction among the digital health has not moved forward. One of the reasons that I remember citing it very well is doctors are not trained to handle that. They don't like to handle it. And there is no demand side created. There's only supply side. Until and unless we look at this very, very in-depth, I think the whole investment in those terms would not bring fruitful results. I think that's something that needs to be done. Technology is advancing, but it's not really supporting the business needs.
Good. I thought that's why the whole set of health administrators are emerging, who help the doctors to link it up. So that's I don't know in Nepal, but I know in other countries where you are a doctor, then you decide to go into the administration, and because the doctor doesn't have much trust on the non-doctor administrators. Yeah. Sorry to say that. So there's a new discipline emerged, who are the administrators, and it's a very good profession as such. Good. If there's no question, then I'll come back to the panelists. Let me start with come on, reverse the seat.
Okay, let me go through the questions. Like the first one is the structure of government, and then the healthcare access. Basically, in Nepal, Nepal has recently gone to the federal structures, like the federalization, and we have 7 provincial government and 753 local levels, local government. And basically, the Constitution of Nepal, 2015, that mandates the responsibility to arrange the essential health services to the local government. But it's like difficult for many local government to arrange the essential health services, and purchase the equipment and also the essential medicines that are used in the local levels. And another problem we have is the no clear demarcation of roles and responsibilities between the federal, provincial, and local government. And some local levels have also made arrangement for the free health insurance enrollment for the citizens, but all the local levels, they are not being able to do so because of their the financial constraint in the local levels. And also we have a target set by the Ministry of Health and Populations to establish one basic hospital in all the local levels, but it has not been able because of the budgetary constraint, and also the remoteness we have. It's difficult to establish a basic hospitals in all local levels. And also there is a problem of retention of health workers in the rural areas. And on the multi-sectoral approach, we do have some of the multi-sectoral plans. We have the multi-sectoral nutrition plans that works with different like, and thematic sectors. And also the multi-sectoral action plan for prevention and control of NCD is also in the place. Yeah, thank you.
Uh, Thank you. So I don't know where to start, but let me go quickly on the primary healthcare focus first, right? So on the primary healthcare focus, I think there are ways to improve. And for Nepal, I think it's part of the legacy, long legacy. Even I remember when I was working as in UNICEF Indonesia at the time, I sent delegation from Indonesia to learn about the frontline health workers, about the FCSVs in Nepal, how they have been working together to support. And most importantly, I think the role is to really bridge the communities and the formal health system, to bring the demand to the surface, right? And in immunization, I think it's been effective. So I would say even Nepal immunization coverage is much better than Indonesia. But there are ways, of course, to improve this. I think I would like touch upon about this whole issue of federal context. So in Indonesia, we don't have that exactly federalization. It's called decentralization, but it's quite similar. But I think one area that is really important is actually to put the accountability to where the service is actually being carried out, right? So when you talk about minimum service standards, which include everything, it's not only about health. It's actually about the overall governance, and it's measured, systematically in terms of performance. And the way we do that, I mean, again, moving forward, is also to actually incentivize good performance, right? And performance-based financing, you know, could be done at that level. So I just want to use an example from what I know in Indonesia, how they do that. They have this capitation fund from the National Health Insurance to also provide primary healthcare providers, including the community health centers. They will get capitation in advance, around 60% or 40%. I forgot now the actual shift, but let's say it's 60% paid upfront before the fiscal year to carry out the function. Once they have completed their performance, let's say immunization coverage of 80%, they'll get the remaining 40%. So you have an incentive to have good reporting. And I would like to touch upon the point about why digital health system work, because it's linked with money. And this is something that we saw also in private providers. I sat with my eye doctor at the Jakarta Eye Center in Menteng. He was sitting in front of me with his laptop open, and he said to me, Budi, wait, I need to enter all of this to move to the next. Waiting to move to the pharmacy. Because if I don't complete the thing that I need to enter in the system, I will not get paid. As simple as that, right? So you have discipline of entering because of that. And this is something now, how, Indonesian telemedicine, for example, during COVID, they managed to expand from 500,000 consultation to over 20 million consultation in 2022, because they have a clear record in the app. When they provide telemedicine consultation, they'll have the money also entered. And I would like to have Pak Aris here, the fintech expert, right? How they manage to incentivize those, on telemedicine with the also e-payment. There are many ways to actually put that discipline. A little bit on also on the uh, uh, local government. When you talk about the reform, it took a long time for Indonesia. From the actual launch of the law, it was 2009 or 10. It was launched 2014. Right? It took some time to take off. But one thing that happened, and it's quite bloody, if I may say, from the history, is the institutional reform to merge all of this. The whole scheme, Social Security Fund, the worker schemes, the what do you call it, the Jam Sostek, for the health worker, for the workers scheme, everything should be merged into one to have the pool, because that's what also make it efficient and effective. The pool should be sizable enough to be able to run the system, right? Lastly, on institutional reform also, and related also with decentralization, and I saw example also here in Nepal, municipality governments, now they showed up and they raised their hand. You know what? I will pay the whole poor people of my municipalities enroll into the national health insurance scheme from my municipality budget. So you have also an affirmative action politically, and you can say that in your election next year, in my leadership, all my poor people in my municipality, they are all paid off. Similarly, also in Indonesia at that time. At that time, how fragmented at that time is every region, every province, they have their own Jamkesda, a regional health insurance mechanism. And by law they should be merged into one system, right? They're not happy. And how can I deliver my free healthcare promise to people? What they did, you know what? I'll buy all. So, for example, Aceh province at the time, I remember 4 million people. Every Achenese resident, free premium, government pays. They can do that. So there are ways actually to also still deliver your political manifesto by actually having, use the system and actually, getting to the, universal health coverage. So I don't know, like maybe that's all quite a lot already, but maybe Ravi can also add, from his wisdom and experience in the region. Thanks.
So yeah, let me address 2 points. One is the effects of climate change, as Dr. Srivastava said. Climate change in terms of, in Sri Lanka, like you right said, vector-borne and waterborne diseases are a huge issue, and they spike up right after, floods or heavy rainfall. Especially, I think one of the examples I used in one of the sessions was leptospirosis, right? So rat fever in Sri Lanka. So this is quite common in Ratnapura area, which in central Sri Lanka, which receives a lot of rain. And the health system there, what they have done is, since they don't have sufficient infrastructure, what the doctors do is, whenever the patients come with a fever, they ask for their occupation. And if they are a gem miner, they'd send them directly to testing for leptospirosis. So, this, and if you miss out, so there could be a delay, which could be fatal, especially in the case of leptospirosis. So you can see, even in this area that consistently face climate risk, climate variability, the health systems aren't ready. They don't have the infrastructure, the personnel to process the test, or get to have a quick response. But even before that, the prevention levels are quite low as well, right? So to prevent the impact, or like the number of cases going up, so that it's both aspects aren't really addressed quite well, even in areas that create climate variability. And now we have these same cases popping up in the northern area of the country, which usually don't have these leptospirosis outbreaks. But in those areas, even the medical professionals aren't trained to respond to these climate-related outbreaks. So, in terms of that, there's a lot of work that needs to be done in improving the capacity of medical professionals and the related, public, awareness and all the other groups when it comes to health-related, or climate-related health shocks. And the other the thing I want to talk about is the tobacco taxation. So, first of all, tobacco taxation is quite relevant in that it is a win-win because it reduces the health cost in the long run, right? So the point of tobacco taxation is to reduce consumption, and we have seen that recently that there has been some success in Sri Lanka due to that. And to also to raise revenue from the government's perspective, right? So financing healthcare, right? So in those two fronts, so from IPS, what we have done is we have identified a network to promote this tobacco control. It's the Ministry of Health, media, advocacy programs, research. So different units are working together to translate the fact that there's public support for tobacco control. So our goal is to translate that into political will and also to some sort of an actionable plan for the government, right? So so that is our plan, and it's not easy because first you need to figure out what the tobacco taxation is going to be, what it looks like, right? So what you have when you design these tobacco taxation, there are multiple components. I'm not going to go too much into detail with those, but figuring out the tobacco taxation formula, then figuring out the stakeholders who are against it, who are for it. So the industry, understand the narratives within the industry. For example, in three big narratives within the industry is it's going to increase smuggling, it's going to increase illegal products, and it's going to decrease revenue. So these are the three myths that that's basically out there thanks to the industry. So because they don't want the taxes to go up, and then also understand the market, right? So in Sri Lanka, what we have is a monopoly, right? So there's so the tobacco, say the Ceylon Tobacco Corporation, they have 99% of power when it comes to the market. So whenever you do a taxation, whenever you increase taxation, they pass through the taxation directly, or more than the amount that's applied, directly to the consumer, which in a sense, I mean, it's good for the government because they do collect revenue, but it also decreases the number of it should reduce the number of smokers due to the cost, theoretically. But we are seeing some signs of that happening. So we need to continue to push this, right? So to make that the idea of tobacco less affordable, right? So accounting for inflation, accounting for income growth, we need to make sure that these are there, and we combat these myths regarding the tobacco industry to have an effective transformation from this, the public support to political will, all the way to implementation of these policies.
Sure. Thank you. I mean, there were a lot of questions, and it's a bit hard to answer all of them. I'll try to sort of get it answered. So I think on the issue of the federalism or the decentralization, I mean, that's a very difficult one because I think it depends on the country context. India is not the Maldives. We have to understand that. You have to understand political culture. But in general, I will make some general points. Obviously, the bigger the country, the more likely federalism is going to be necessary. Secondly, usually the federalism and the decentralization, even in Indonesia, it's not determined by the health sector. It's determined by other sectors, the political economy. So the health sector is a taker, not a giver, right? If I use the economic term. So I think we just have to deal with it. But some general points. I think that in general, I would say for health service management, whether you're federalized or not, it should be probably decentralized as much as possible. That's what Sri Lanka did in the 1960s on. It's one of the things that we changed internally within our centralized Ministry of Health. Secondly, I think on the political economy about political accountability, it depends on the culture and context. If I look at India, and I think India is much more, the Indian states are much more different from each other in terms of political systems and culture than, say, Indonesian provinces. And I think that's reasonably fair to say. Or Bangladeshi, I don't know, divisions or whatever, right? And Bangladesh is fairly homogeneous, right? Even though you have a lot of people. So why is that important? In India's case, if you look at the issue of political accountability, the one part of India that's done really well on UHC in recent years, not Kerala, it's Tamil Nadu. And Tamil Nadu has a political system like Sri Lanka. They've had two competing parties competing for power for the past 20, 30 years. Both used to be led by women as well. And that was critical in creating the political pressure. It's a very similar story to Sri Lanka. So Tamil Nadu, and they would hate to admit it, I'm sure, has moved closer and closer to the Sri Lankan way of doing things without necessarily copying us. Okay, and that's one thing. So I think it depends on political context. I think about federal systems. I think it's probably inevitable in terms of financing that you still need a strong central financing redistributional role. If you take health in the United States is state mostly, but Obamacare is a federal intervention, and they bribed the states. 90% of the money for the states came from the federal government, right? Australia, federal country. But in fact, if you look at their additional funding mechanism so taxation is mostly at state level and they have their own health ministries, but they have an additional funding mechanism that is Commonwealth, central, federal government. And that ensures the equity, right? So I think there's some role for central financing. Now, just a couple of things about, there's some issues from there about the rural areas, public-private, and maybe what Sri Lanka was doing. So I think the point I would make here, two general points, and these sort of general points. Most of us cannot follow and implement a UK NHS or Swedish type system. We don't have the fiscal resources. Sri Lanka doesn't. And the political support doesn't exist. Why did the UK did it? It was in very exceptional circumstances at the end of World War II. Very exceptional circumstances, right? Probably not replicable. Today, if they had to do the NHS in the UK, they probably wouldn't be able to do it, right? It was very unusual circumstances. Thailand, Takshin, in very, again, exceptional circumstances. Once they did it, it stuck, right? You can't get rid of the NHS. You can't get rid of Takshin's reforms, but even if you hate him and demonize him, that reform stuck. So I think political opportunities. But what did Sri Lanka do and Malaysia do, and Australia actually? They couldn't do the NHS. And we don't have the fiscal resources to provide good public care to everyone. So what we've done is we've ensured that the free public delivery reaches the poor. Now, there are two parts to this. Poor meaning and rural people and remote people and marginalized and blah, blah, blah. Two things. There has to be, I hate using political will. I mean, I used to get, my graduate school, I had a political scientist who taught me, he hated the word political will. So I'd rather not use it. You have to have a political system that is responsive to the interests of the poor and the rural people. So Sri Lanka, we have a good health system because we're the result of a social experiment. In the late 1920s, our British occupiers decided, for some crazy reason, they would give women the vote. And they did it to improve health conditions. Everything else followed from that, right? Malaysia and Sri Lanka also have this feature. Rural constituencies historically they needed fewer votes to get an MP into parliament. The electoral system was jigged in favor of rural voters. Japan also has that as well, right? So you have to have a political system, and you have to have competing parties, and you have to have parties who think they can lose I think in Bangladesh, what happened recently was the government probably felt it couldn't lose an election, so contestability declined. And I don't want to get into why, but I'm sure the Bangladeshis know. I think you have to have contestability. You have to have the threat, not of COVID, the threat of losing power.
Yes.
Right? That is more important than COVID. It's the threat of losing power that makes politicians think. So you have to have that. So in Sri Lanka and Malaysia's case, we built health services that reached the poor rural people. They were everywhere, physically close. And then because people don't like user fees, we abolished them in the 50s. Right? And the doctors want user fees and the finance ministry wants user fees. No way. Politically, it's not feasible. So we need to think about politics. And I think, how do we bridge that resource gap? Because we can't provide this. What we did was we made sure the public sector delivery system is genuinely accessible by the poor and rural people. So they use it. And then the better off, they don't like the queuing. And, I don't go to a public hospital in Sri Lanka. I'm completely honest. Right? None of my family go to a public hospital. Right? We go to the private doctor or the private hospital because we rather choose our doctor.
I go when I have a friend there.
When you have a friend there, yes. I might also have friends in the public sector in Sri Lanka. But in general, we go because we don't want to wait in the queue or sit in a big ward or whatever, right? And we can afford to pay, so we go private. That's our system. But what it's done is it makes sure the better off people go to the private sector voluntarily. No one's forcing them. I can still go to the public sector and get free treatment, and the poor people use the public sector. That's how we have managed. So that's what Malaysia does, Sri Lanka does. It enables them with only 2% GDP government expenditure on health to achieve UHC. Singapore does that, though they have some, I think. Hong Kong, second best health outcomes in the world. Their health expenditure from the government is about 3%. It's like ridiculous. Singapore. Australia. Australian GPs, because they never did the NHS, are fee-for-service private GPs. But there's some public funding, subsidies for them. But all of these countries got around the NHS approach by essentially balancing public and private. And I think the key thing here is the public money needs to cover the poor people. If you're not doing that, if your public hospitals are used by rich people, your public insurance, you said in Indonesia initially was used by rich people, no good. It needs to meet the poor people and let the private, the rich people, they can pay privately. I don't care about them. They don't need insurance, they can manage, right? They can always manage. But I think that's what we had to do. And that's I think, for many of us in South Asia, I think has to be the way forward. Because I can't see Pakistan and Bangladesh and Nepal honestly being able to afford an NHS. And honestly, they can't afford the tax premiums to pay for national health insurance. So we have to think about how does the public sector reach the poor? And then there are a lot of other issues. I won't get into that here, but I'm happy to discuss later.
Thank you. We haven't talked about regional collaboration. Maybe since we have about 10 minutes, what do you think? Is this an area where we could have regional collaboration the way it emerged in the climate change? That, you cannot address climate change unless you come through a regional approach. Is it the same truth, or no, it's country-specific issue? So we have to look at country-specific regulation. Any idea? Yes, please.
So I think I will first start with the strength of the region as a whole, right? To start with.
When I say region, South and Southeast.
Exactly. Yeah.
Sorry.
So the strength of the region, and this is something that we UNICEF also has been working in terms of really strengthening the regional community. So one area that is really important, and this is again the learning from COVID. I think there is also an opportunity to strengthen our regional supply chain collaboration, because that's also a key features in UHC, right? When you talk about medicines, I think this region is still unbeatable in terms of price to make the UHC affordable. As compared to Indonesia, I bought medicines here like very cheap, right? So, and because of also the the market share and the supply share, in exactly, So that's also an area where we have been working on vaccines in UNICEF. So because then if you strengthen that regional supply chain hub, then you have cheaper vaccines, you have cheaper medicines, then make UHC affordable. Secondly, I think the one thing that I've mentioned is really on the digital health collaboration, because we have good examples. Problem is how we cross fertilize, make it more contextualized, to different settings, right? And I think we have that opportunity. We have the expertise in the region. We don't need to have examples coming from, for sure, from United States model. I mean, it's all here in the region, you know, the whole collaboration framework. And I don't know if you notice, actually, uh, the start of regional collaboration is really in this region, because somehow, when preparing for this talk, I read about 1937 meeting in Bandung, Indonesia, of the League of Nations Health Organization conference. At the time, Indonesia is still under the Dutch colony. You have a history of actually a regional collaboration, and then also Indonesia was the place. Bandung again is the place of the Asia Africa Conference, non-aligned movements. So you have already already a culture and history of regional cooperation, quite strong. So I think we can leverage that. And for health, I think again, this is something that we should work on. So um, the thing is that also a bit difficult. I should also make this open, in health, right? I think the fragmentation of governance of regional cooperation, right? Despite the fact we have the South Asia regional cooperation headquarter here in Kathmandu, right? But how is it function in terms of nurturing regional exchange in health? Because in health, we have the two regions, the CRO region of WHO, and the other part there somewhere else, right? In Middle Eastern region. Uh, Next year, I think also Indonesia will be moving to WebPro. We're getting out from CRO. So again, you have a bit of difficulties in terms of that, but I think there are some natural opportunities that we can use. And the SARC, again, sitting in Kathmandu, is maybe something that we need to try to capitalize and work on small issues. Let's say on, some of the uh, skill development or knowledge sharing and exchange learning, on universal health coverage. Thanks.
On the regional.
I would tend to agree. I mean, I don't think there's much we can do regionally in terms of financing, because ultimately financing is a domestic political issue. And frankly, if you can't get your rich people to pay up, why are you going to go and ask some rich people in another country? I mean, I also get, I'd say, very irritated about even Sri Lankans who go, oh, we need foreign aid. Yeah, but why would you expect British rich people or German rich people to pay taxes when we don't want to pay taxes? Like this is
speaking.
right. No, I mean, I'm just being. It's for me. It's almost immoral, that kind of approach. We have to sort and confront our own internal challenges. But in terms of where sharing, I think, can be useful is the knowledge, experience sharing, and that we need to do a lot more of. The problem, yes, I think, as you notice, I also know that there's a lack of adequate regional mechanisms. SARC is less said the better.
Long live the king.
Yes, less said the better about SARC. ASEAN is, I think, a lot better, to be honest. And I wish Sri Lanka had joined ASEAN in the 1960s. No, we were invited as a founder member, and we turned ASEAN down due to stupidity of our politicians. But I think also, and I think CRO is going to have problems. I know Indonesia has it made a formal decision to leave, or okay. I think that's probably going to be bad for CRO. I think the Thais might stay because they're probably have more influence than the remaining bit. But maybe all of us should quit and join Wipro, because in terms of learning, particularly for Sri Lanka, and I'm just being as a Sri Lankan, we have historically learned from Australia back in the 1950s. That's why we have our good health management systems from Australia. We've learned from Malaysia. We look at Singapore. We look at other countries in Southeast Asia. And so maybe, if you brought up the issue of Ciara, maybe we should just abolish Ciara and all of us join some Asia branch of WHO, because I would worry about the segmentation that's going to create and the lack of sufficient experience.
You're not talking about Indo-Pacific Health Organization.
No, I don't use Indo-Pacific. I think Indo-Pacific is a very colonial term from some hegemonistic superpower above there, but I won't mention that country. No, I think that's what we need to do. And I think that sharing is important. And I think particularly for healthcare delivery, I mean, there are countries like Sri Lanka and Malaysia which have managed well with limited fiscal resources. Malaysia, I know, is a lot richer than most of us, but still they have managed with a system. And I think we need to learn, and I think we need to be willing to learn even from Australia. And I would just mention on technical sharing, I was recently, we had some regional work with Indonesia as well on digital electronic vaccination registers. And we took them to Australia. And two things about that. Digital in itself cannot solve the problem of bad systems. So Sri Lanka has better vaccination than Indonesia, even though Indonesia is ahead of us in electronic registers. Australian experience is interesting because the Australians were the first to do it in the digital vaccination space, but they started off with a system that defaulted to paper. And what all these other developing countries are trying to do, they're trying to jump to electronic without having fixed the paper system first. And we're struggling. And so in Indonesia and Bhutan, I know there's problems with the digital registers for vaccination because it doesn't cover everyone. It doesn't cover the poorest people. And we're supposed to be concerned about those people, right? It doesn't cover the remotest areas. Australia did it the other way around. They started with a system which would work even in the most remotest part of Australia where there's no internet and there's no computers. And then they expanded to electronic. And I think there are lessons we can learn, and we should be careful about how we handle and bring in digital technology, because digital technology is not always inclusive. And I think we need, not everyone has a smartphone. In Sri Lanka, the poor people do not have smartphones. They probably don't have a phone sometimes, right? So I think we need to be realistic and balance all these different interests.
Good. Thank you very much. With this, we are coming to an end. I will have a... Yeah, please.
Quick point. So yeah, fully agreed, Ravi. And I think one thing that I've tried to also insinuate in my point is also on the community engagement part. So this is where I think, again, when we see about UHC, sometimes we push on the supply side part, but not in community engagement, even in terms of the strategic, community advocacy around the importance of this, right? Because I think one area that we see clearly that we saw also from the experience is that even now in Nepal, there is this tendency of the not willing to continue with the premium payment because of the perception of lack of use. I'm paying premium, but I'm not using it. Why should I? Right? This whole socialistic solidarity about pooling, of the resources actually and to be grateful that I don't fall sick and I don't need to use it, is somehow also a bit challenging, right, in the context. And this is something that we saw also in Indonesia. But the point is, I agree with you. So the focus of the government should be really about these poor people. That's where I think for Indonesia it's very clear that 40% of the poorest pay fully by the government. And again, like if you can use also some of the market arrangement in the insurance. So there are classes of the BPJS card, right? The premium, you can go to a privatized wing of a government hospital, like the Cipto Mangunkusumo Hospital in Jakarta. They have the private wing basically. You can use your gold or platinum, BPJS card basically to access, or you can top up by your private health insurance, like what many of us use. So you have private health insurance for conditions or things not covered in, and you don't want to go to exactly to the queue of 1,000 bedded hospitals in Jakarta. So you have that also, a strategy that you need to be, and lessons learned in terms of strategy of communicating this also, but at the same time also community engagement, and even also putting the local leadership in the center, when you talk about universal health coverage, because this is something that when you have that dialogue at the local level, you could see the example like what we saw in Nepal, having mayors and deputy mayors committing to actually pay the premium for all the poor people in their municipalities. Thank you.
Thank you. If there's no more questions, we are I will conclude. This is the first time I see that Marxist and capitalist somehow or other converged on the health issue. Well, congratulations for that. That 40% of the poorer should be taken care of the government, and we'll take care, the market will take care of the rest. So it's a coexistence which I see in Asia, especially coming from Indonesia and Sri Lanka, a little shaky in terms of that. But that's a good way of trying to address realistically, progressively the issues. I also see that then it is a issue of policy, politics, and governance, whether it's a federal government or a unitary government. So that's one area based on which then you have to have your own approach. On the regional issues, collaborations, I hear that it's a subject which possibly will have difficulties, except sharing the experiences and the innovations. Other than that, WHO-like organization possibly wouldn't survive, and we shouldn't create one. We had enough of those. And I see overwhelming kind of a focus on the private sector, except on the insurance for the poorer sections, and which when I talk to my colleagues from the other end, they fail to understand why insurance should not be prescribed, shouldn't be taken as priority areas by even the government and the private sector, because most of the poorer people wouldn't understand what insurance is all about. They end up going to their local landlords or money lenders. That's what we haven't talked. If you are sick, if you don't have money, you sort of go to the local money lender and give your land and say that I need, my father is on the deathbed, and that keeps on exploiting him for the rest of the life. That's the other part. So government has a huge responsibility, if not for anything else, for the re-election purposes, help those 40 or 50%, and I think that will be one of the areas that we will try and bring in. The area that we haven't talked about, vaccine, that could be an area for collaboration. I know we had a bad experience during COVID, but we can always build on the. No, I'm not talking about the WTO patent issue. I'm talking about the local collaboration between countries where countries paid money and never got the vaccine. So that's an issue, but that's an area where collaboration could happen, both in terms of digitalization, insurance, and what you call vaccine industry, where there's a lot of interest in the foundation. With this, I land. Famidapa, if there's any logistics, is all yours. Thank you very much. It has been a very rich, rewarding experience. Thanks to all. Thanks to all. I did not expect this to be so rich. Don't ask me why, because I'm not a doctor. I have very little exposure to the health sector. So, but I learn more than anyone else here. Thank you very much.
Thank you very much, Professor Shahidul Haq, and the panelists and the audience. Really a rich discussion. And I was particularly happy to see a technical issue has expanded to other branches as well, including politics. So which cannot be, divorced from this health management issue. So only thing I have to say that I would like to invite you to the lunch, and we have a session in the afternoon as well. So I hope that and request that you would be in the session and participate in the discussion and make it a really, very interesting and learning session. Thank you.